Good morning, everyone. We are going to get started. Hello to everyone here, and then to those on Zoom. I know that many of us are joining us from ID Week or remotely. Welcome to HIV Grand Rounds. Before I introduce our illustrious speakers, I'll just say one exciting element of the day is that there may be a fire alarm that goes off at 9 a.m. If this happens, we will just take a quick pause and have everybody join by Zoom. And Dr. Coates will present the second half remotely from a second location. So if that happens, we'll move. If we aren't kicked out, we'll just persist here. Without further ado, I will turn the microphone over to Dr. Herbert Castillo Valladares, followed by Dr. Sarah Coates. They're both phenomenal assistant professors of medicine in the Department of Dermatology, who are phenomenal clinicians and educators at the overlap of HIV and dermatology. We loved their talk last year. We made them come back again, and so they will be giving us an updates in HIV dermatology. Thank you too for being here.
Good morning, everyone. Thank you again for this kind invitation. We're really excited to speak to your group, and we have some exciting updates in the front of derm and as it intersects with HIV. So we have no relevant disclosures, and our learning objectives for this talk is to first describe the clinical morphology of some important viral infections, including Mpox and acyclovir-resistant HSV. And then we're also going to go into some updates about treatment for Mpox, including with Tegavir-Met, and then also talk about the efficacy of the Mpox vaccine based on some observational studies that have been collated very recently. This is hot off the press. Then we're also going to spend a little bit of time talking about treatments for acyclovir-resistant HSV. So we want you to walk away from today's talk knowing at least 2 different treatments that can be suitable for outpatient treatment. And then we're going to end with some continuous drug eruptions relevant to patients living with HIV, and also identifying some skin signs of nutritional deficiency. So we're going to get to it because we don't want the fire alarm to disrupt the cases. So case number 1 is actually for a case of a patient who's HIV negative, but I think it does gonna sort of open the discussion about an important topic that's relevant to patients living with HIV. So this is a case of a 47-year-old who had a previous history of Mpox infection at the height of the outbreak in 2022. And here you can see the picture of a very classic morphology, which is this eroded papule in the genitals, in the shaft of the penis, surrounded by this very indurated and edematous plaques. For patients, this is very painful. At this time, he was treated with Tegavir-Met, and then he also subsequently received 1 dose of the modified vaccinia vaccine, the Genios brand, in 2022. So that was his story a few years ago. And then as part of my job, I'm sort of spread throughout the campus. So I do inpatient consults, I do teledermatology, and then I also do outpatient clinics. So this was an inpatient consult. So he initially presented to his primary care provider with 3 days history of these lesions associated with mild pain. And then reported that he had 2 sexual partners, both were men, and he engaged in condomless and sort of anal sex. As you can see, these lesions are these erythematous papules with a central crust. Some of it is a little bit yellow, some of it is a little bit honey crusted. And it's distributed over the forearm, the scalp, and also the left face. So my question for you, after knowing a little bit more about our patient, what do you think is the most likely diagnosis based on the most recent images? So the hand, the scalp, and the left face. Right, I'm gonna give people some time to think about it. And the answer for this, yeah, so most people are sorry, so most people are still answering. Some folks are saying Mpox infection. Some folks are saying disseminated gonorrhea. So yeah, it does have a broad differential diagnosis, so that's why I included all of the answer choices. For this patient, the diagnosis was Mpox reinfection in the setting of previous infection and also incomplete vaccination. So this brings up a little bit more nuance that we are, accustomed to when we have a patient who's just presenting with the first infection. So I just wanted to give you the timeline to sort of dive through all the details so that we really understand what might have happened with this patient. And so if we go back in time before the derm consults, 3 weeks prior, he was swabbed for the Mpox PCR, which was positive for clade 2 Mpox. So clade 2, remember, is the outbreak that started in 2022. Clade 2B and then clade 1B is what the outbreak that's happening in Central Africa and East Africa in the Democratic Republic of Congo. So we know that it's clade 2 Mpox, so the outbreak that happened in North America and Europe and the rest of the world that is still happening in sort of low transmission numbers. And then he was actually enrolled in the STOMP trial. We don't know if he got tecovirimat versus placebo, but because these lesions progress, so at the top here, you can see sort of a very erythematous, indurated, and necrotic plaque on the shin. This prompted him to be transitioned to open label tecovirimat trial due to the pain and the progression of the lesions. And despite being an open label trial for tecovirimat, he continued to get more lesions. So 3 days before the consult, so this is 3 weeks into his whole disease course, he continued to get new lesions. The left face was swabbed and was also positive for Mpox PCR clade 2. And then around the same time, he also had rectal gonorrhea, the test that was positive, and he was treated with ceftriaxone. So then we came in because we were called because the lesions were not improving and there were more lesions. So this is what we saw when we saw him in the hospital. There were more lesions in other unaffected areas. So this was the original plaque that was progressing, and then superior to that, there was another red papule. And then on the other hand, the left hand was the original affected extremity, and then on the right hand, he had new lesions. So then we decided to do a diagnostic workup to make sure that we weren't missing anything. And what resulted from this, so before all of this, we saw the morphology having some crusting and a lot of erythema. So we thought that it would be helpful to recommend an empiric course of cephalexin because we thought we had a suspicion that the patient had some superinfection. Luckily, the repeat Mpox PCR of all the lesions that we swabbed were negative. His RPR was negative. HSV and VCV were negative. So all these infections are on the differential for these lesions. And then when we got the bacterial cultures back, it confirmed our suspicion that these were superinfected with both group A strep and Staph aureus. And the skin biopsy didn't show any further Mpox histopathology. What we saw was a neutrophilic leukocytoclastic dermatitis, which would be consistent with a suppurative process like a superinfection on the skin. So after he continued on the TPOXX and the Keflex, you can see that the facial lesions resolved and the erythema around the initial lesions on the left extremity improved. And so we think that the superinfection was really driving a lot of the progression in this patient. This is another sort of picture depicting the improvement on the shin lesion. So I want to talk a little bit more about the classic Mpox clinical presentation because I think it's useful to compare this first patient who had a very prolonged and extended course that was complicated by superinfection with sort of the typical classic presentation of clade 2B Mpox. And so the progression of lesions goes from macule to a papule to a vesicle to a pustule. So it's this rapid progression that then necrosis and scabs and then reepithelializes. And it should take approximately 2 weeks for the entire course to happen. As you remember, for this patient, we were on already week 4 and things were still worsening and new lesions were appearing. And so that's why he was transitioned to open trial tecovirimat, and then also started on the antibiotics that ended up also helping a lot. It's also important to know that all these lesions have a prodrome, right? So before all the skin lesions, there's fever, myalgia, headache for most patients. And so if you have a patient that presents with this is highly suspicious for Mpox, and it's still happening at low levels in our community. The clinical presentation for the current outbreak in Central and East Africa is not different. So it's the same progression and the same lesions, but the mortality rate is a lot higher. So the mortality rate for clade 2B Mpox is about less than 0.1% globally. For this new outbreak that's happening currently, that's continuing to emerge, it's about 10%, which is, especially for other populations, including immunocompromised populations, it's higher. In thinking about this patient, we are also thinking about whether or not tecovirimat was helping this patient, whether we should be suspicious about tecovirimat resistance. So I just wanted to highlight a few data about the efficacy. So we don't know for clade 2B what the efficacy is. That's why the STOMP trial is ongoing. And if a patient has severe disease, then they go into the emergency access for an investigational drug. For clade 1 Mpox, there was a randomized controlled trial that assessed approximately 497 children and adults that basically resulted in no reduction in the duration of Mpox lesions, but we don't know about clade 2B. And when we're thinking about resistance, there's actually documented phenotypic resistance, specifically about the F13L gene, which is involved in the envelope of the protein, and this resistance is happening more in immunocompromised patients who are receiving really prolonged courses of treatment. But more recently, there's been community spread. So there's been outbreaks that have been reported of tecovirimat resistance and Mpox among people who have not had any tecovirimat treatment before. And this has happened in California and other states across the country. And lastly, I wanted to quickly just think about the vaccine, right? So our patient had one vaccine. Usually, our recommendation is to do 2 doses, spread out by 4 weeks. And in the table, you can see who is at risk, who the CDC considers at risk, and who we should be recommending a vaccination. And the efficacy is between 66 to 89%. So we know that it's not fully protective against Mpox, but breakthrough infections when people are vaccinated are milder and less likely to lead to hospitalization and death. And this is a very recent table. This paper just came out on Monday. Just a really nice review on JAMA that sort of compiles all the observational vaccine efficacy for both 1 dose and 2 doses of Mpox. And as you can see, for 1 dose for the modified vaccinia vaccine, which is the Genius vaccine, it can be as low as 35 and 35.8. So it makes sense why our patient who only had 1 vaccination had potentially lower vaccine efficacy. So take-home points, we reviewed the clinical morphology and the progression of Mpox. We showed a case where reinfection in patients with a prior infection and vaccination is possible. And then we went through some of the data about tecovirimat efficacy and resistance. And we also show some of the vaccine efficacy, which is 66 to 89%. And then we also showed an example of how bacterial superinfection may lead to a prolonged and atypical course. We're going to move right along to case 2. So as I was explaining before, I'm spread through all of the campus, and I'm inpatient. I saw that patient in the inpatient setting. And this is a very typical e-consult that I get, a teledermatology consult that we're seeing more increase of. So I'm actually not even going to share a lot of information because this just came as a picture and it said rash. And then I had to figure out what it was. And so I want you guys to look at this picture, stare at this picture, and take a moment to identify what you're seeing, come up with some evidence of why you think what you're seeing is what you're seeing, and then we're going to move on to the question. Right. Based on the penile erosions that you saw on the glands and also a little bit on the prepuce of the penis, what would be your diagnosis? Perfect. Thank you all for participating. So I think most people are thinking HSV infection, and maybe my learning objectives sort of biased you, but actually this is not HSV infection. This is a fixed drug eruption. And why I want to bring it up is that this is coming at higher volumes than we've seen before. And we sort of have an idea of what's happening for both that patient and sorry, before even jumping into the discussion about both of the patients, I just want to make sure that we all identify the key features. So fixed drug eruption happens at the same site every time the patient is re-exposed to the culprit drug. So it's not going to happen the first time the patient takes it because it's a type 4 hypersensitivity reaction. So it's going to happen after the patient is re-exposed and subsequently every time the patient takes the medication. So it's a drug allergy and the patient should not continue to be exposed to this because it's going to recur at this. But the interesting part, and no one really knows why this happens, is that it's the same part of the body. And a very common culprit or list of culprits is antibiotics, but specifically tetracycline. So in the patient that I showed before, after I dug a little bit more in the chart, this was the second time that he had this eruption. And it happened every time he was taking his doxypep. And so this was the same presentation as well. General mucosa ulceration that's supposed to be oval shaped. You can see here how it's oval shaped. And then also oral mucosa ulceration that is oval shaped. And what was the key piece of evidence here is that there was some cutaneous involvement too that is also resembling an oval shape. But it can mimic a lot of infectious etiologies, right? Like this patient was treated for HSV. This patient was empirically treated with penicillin for, multifocal syphilitic chancre. You can even think of Mpox affecting the oral and general mucosa as well. But in this case, again, it was repeated at the same time. And then a lot of what is happening too, anecdotally, right? We don't have any evidence of this in the literature yet. But when patients are taking doxypep, sometimes it's very infrequent. So they take it, they get the fixed drug eruption, they heal, and then they forget about it, and then they take it again, and then it recurs. And so this is the classic fixed drug morphology that is in the textbook. So I just want to highlight here sort of the oval shape here. You can sort of see how well defined it is. And this is a very fast progression over 2 days. It became very dusky. And that's what we're accustomed to seeing on the skin. But there are other morphologies, and all of these cases are of patients living with HIV, mostly well controlled, but also taking doxypep. So this is multifocal and bullous. So you can see again, 1, 2, 3, 4. So all the oval shapes, you can replicate it, but the key here is that it might not just be in 1 or 2 spots. It might not just be in the oral mucosa. It might be in a lot of places, and it can actually, if it's intense enough, the interface reaction happening on the skin actually leads to bullae formation, as you can see in the 2 images here. More morphology so that you recognize this. Again, just pointing out the ovals. And then sometimes what you can see in people's skin is actually not necessarily the erythema or the dusky activity, but instead it's a hyperpigmentation because the patient, for some reason, stopped the medication, and then you have these dark spots. So this patient was really bothered by the hyperpigmentation and the resultant hyperpigmentation. And for him, it was also very tricky because at the same time that he was taking doxycycline, he was being treated for H. pylori. So he was taking multiple antibiotics at the same time. And he was also taking a little bit of ibuprofen here and there because he had a little bit of joint pain. So all of those are like high culprits. And so this is a little bit of a difficult situation, right? Because you don't want to just stop every antibiotic known to man because, you want to make sure you identify the drug. And so what we can do in the outpatient setting in dermatology is do patch testing to the specific medications, the specific antibiotics that are on your culprit list. And for him, it was important to actually put it. Remember when I told you that it happens in the same location every time? So if you put the typical patch test that happens in the back, it might not be completely sensitive. And so what they had to do in the patch test clinic is actually put the medication on the spots where he's known to react to see if it was reactive. And so that ended up helping us figure out what the culprit was for this patient. So take-home points for this case is that fixed drug eruption creates well-defined oval-shaped dusky plaques, and they can recur at the same time. And a lot of the times it involves oral and genital mucosa, it can mimic chancres, HSV, Mpox, but it can also have different morphology, including multifocal, generalized, and bullous forms. And with the increased use in doxyped, PEP, what we're seeing in clinic is potentially more increased visits for this cutaneous side effect. So just be on the lookout for this. All right, how are we doing with time? Perfect. And no fire alarm yet. So that's great. Case 3. And so this is just going to be a gimme right off the bat, because I really think that the treatment for this is something that we are continue to investigate. And so the next 2 patients have acyclovir resistance HSV. And this is a before and after what we did here in Derm Clinic with injections of cidofovir. So you can see how this is not a typical HSV morphology, right? This is a lot more heaped up, more verrucous, very thick, indurated, and super painful. So this patient had he had great impairment in his quality of life. He had a lot of pain while defecating. Even just sitting down for him was really painful. After doing some injections, it scarred. It was less painful or not painful at all, and it resolved. It's a very similar morphology here, very similar location. This was HSV acyclovir resistance, and then this patient had an even better response. Their skin was completely flat afterwards, and all the pain and impairment that happened because of these lesions was addressed with intralesional cidofovir. And so these are 2 very recent examples of what we're doing in the outpatient clinic. And cidofovir works really well, but it also is very difficult for some patients based on their social drivers of health to present to clinic for intralesional injection. So we really wanted to know what was out there in the literature to figure out what the most efficacious treatments were for outpatient treatment of acyclovir resistance HSV. And here I just want to highlight the morphology, just like fixed drug eruptions were ovals. What I typically see when I see HSV, even if it's acyclovir resistance, it's sort of this like puffy cloud with scalloped edges. So you can see how there's scalloping here. And what I think of in my mind and what helps me remind and what is useful in the clinical evaluation of this patient is if it sort of resembles this puffy cloud, and I'll show a few examples later on. A lot of the pushback that we got when we were trying to publish some of our data is that people have this idea of acyclovir resistance HSV as being a very high mortality disease that has to be managed in the inpatient setting. And that's right for a subset of patients, right? Like very immunocompromised patients can have very severe presentations of acyclovir resistance HSV, and these are some examples. But as you compare that to sort of the single lesion that we have seen outpatient, we really posit that a lot of patients who have acyclovir resistance HSV actually can be treated in the outpatient setting. And this is a little bit more about HSV clinical morphology that I want to just hammer down one more time. So it starts off as red little papules that then create vesicles and then can become scalloped erosions. And again, if you see the little cloud here, then you're getting sort of what I'm trying to convey here about the morphology of HSV. And I think it's important for us to understand how to get our highest yield diagnostic test, because a lot of the times we have high clinical suspicion and then the test comes back negative. And the reason why is perhaps because of a inappropriate sample. So what we typically do is puncture the vesicle with either a large gauge needle or an 11 blade. So that makes a little entrance for then you to go in with your swab and then lift off that vesicle, unroof the vesicle. And you really have to get in there and swab the base. And so if you're not doing it with firm pressure on the base of the lesion, it's probably not going to be very accurate. And so I just wanted to make sure that people had an image in their head of what happens when you're taking an HSV swab. And why there's acyclovir resistance. I'm not going to bore you with this beautiful icon that I created, but the important part here is that acyclovir needs to be phosphorylated by this important enzyme called thymidine kinase. And if there's mutations on it, like there are in acyclovir resistance HSV, then acyclovir cannot enter the virus and then inhibit viral DNA synthesis. And so that's what happens with acyclovir resistance HSV, and acyclovir then becomes not relevant. And so we need to figure out other treatments that are not dependent on thymidine kinase or phosphorylation by thymidine kinase in order to treat patients. And so what we found were 88 studies. We did a systematic review of 88 studies. And I want to highlight some of the important ones that I think you can walk away with in your toolkit to treat acyclovir resistance HSV. So foscarnet is sort of what we think of as a second line for HSV treatment, right? And this is only an IVI medication, and patients have a lot of the times need to be hospitalized because of all the side effects that are associated with IV foscarnet, which include renal toxicity, electrolyte abnormalities. And as you can see here, it leads to improvement about in the reported literature about 57% of the total N. And we reviewed clinical trials and many case reports that confirm this. There we go. Is that it? I'm gonna keep going. And the interesting part here is that we can borrow formulations from other specialties. So trifluridine is actually an ophthalmic solution that is used in ophthalmology to treat HSV keratitis or ophthalmologic involvement of HSV. But you can put it on the skin because it is atopical. And so there's a clinical trial that evaluated this, and then one case report, and there's about a 30% complete response to this. Again, something else to have in your toolkit, not necessarily the most efficacious. Cidofovir is what we use here, and we have a protocol where we can gather interlesional cidofovir, and IV cidofovir is also an option, but it has a lot of side effects, including renal impairment. So that's why we opt for the interlesional formulation. And we can do that in our clinic. So if you have a patient with this, please coordinate with us and we can do that happily for you. But interestingly, what came up in our review of the literature is that imiquimod is also a potentially efficacious treatment. And imiquimod, you can do a 3 times a week protocol. So patient puts it 3 times a week for about 8 to 12 weeks. It's a cream. And so they can do this outpatient. So again, if someone has issues getting to the clinic to do interlesional cidofovir, which happens about every month, this is something that maybe they can go home with and apply at home. And then the exciting new medications on the block are pritelivir and amenavir. Amenavir is available in Japan. Pritelivir has an ongoing phase 2 clinical trial comparing it to foscarnet, and it's an oral medication. And in these patients, there was 100% clearance and no side effects. So this is sort of what it's really exciting in the let me see here.
We're doing the evaluation drill, so evaluation required. You guys take a 15 minutes.
Perfect. Just as I was going to finish. So, so this is sort of what I wanted to convey with the last slide for this case is just a treatment protocol for you all to think about what treatments are out there for your patients. So test for drug resistance, and then there's various different options for you to consider.
Hi, everybody. While we are switching our AV stuff around, I might, Herbert, if it's okay, do you mind answering this great question in the chat around mechanism of fixed drug eruption and or like timing at which you might expect to see?
Yeah, so it's quite fast. So once you've been sensitized, it's like it happens in a few days. And then I think the second part of the question is shortly after I've encountered patients who develop fixed eruption shortly after using the medication or months to years after, and some who have developed it then go on to using. You know, I do question whether or not there was another medication that was actually causing the, because like we see this all the time. There's actually fixed drug eruptions to like sometimes even foods. Like this is very rare. So like don't go sort of restricting people's diets. But it got to the point where, you know, we were going through all of the potential, like even like food dyes that can present with this type for hypersensitivity. So it classically should be takes the medication, a few days later gets the rash. It doesn't necessarily, I would say that if it happens very delayed, like months to years, it probably is something else. And if they don't develop it again after medication administration, then it was definitely something else, because this is something that you don't necessarily become immune to. So it should be fine. Right. A few days, I mean, it's like for some patients, like a day after. For others, it's like, so I would say maybe like a day to a week after administration of the medication.
Perfect. Thank you. And then Joe, do you think we have time for one more question? Maybe Herbert, if you want to start bringing this question around folks who had prior infection and vaccination.
All right. Right. Yeah. No, I'm not recommending. So the guidelines is not, so if the patient has had an Mpox infection, they do not need the vaccination. So this patient just happened to have access to a dose, and then he obtained it after his infection. If a patient has one dose of the vaccination, and it's been more than 4 weeks after the vaccine, which is sort of the time frame that you want the vaccination to happen, they are still eligible for their second dose. So they should still get it, but I am not recommending vaccination after infection.
Thank you so much. Okay, perfect. Thank you, everybody, for hanging with us. We will rejoin.
Hi, everyone. Okay, let's just make sure that this is working. I see all the participants. I see myself. I see my slides. I think we're good. Yeah. Hi, I'm Sarah. It's so nice to be with you today. Herbert you are just such an incredible clinician. I love that. Thank you so much for those cases. I am excited to share with you a couple of things. And as I thought about what I had to add from what we talked about in Grand Rounds in the spring, I was reflecting back on my time in my Fogarty Fellowship in Uganda when we started a clinic in HIV dermatology that we hope to sustain long-term for people living with HIV at the Infectious Diseases Institute. And I wanted to share with you a couple of pearls that I took away from that experience, which I think really translate really nicely to this setting. And so I hope you agree, and happy to be able to share this with you. So our first case is a 43-year-old woman who had well-controlled HIV, who came in with a 2-month history of an itchy symmetric rash on her arms and on her neck. And I'll show you the pictures from her neck. So what we're seeing here is these really pretty well-defined shiny plaques on the forearm, dorsal forearm, and the upper back and neck, with a little bit of peeling quality to the scale. And again, these were itchy, had been going on for a couple of months. Here's another representation of what she was experiencing on her upper shoulders and her clavicle area. So my question for you is, what was the most likely diagnosis for her, just based on the clinical morphology alone? Was this a photoallergic contact dermatitis, a photodistributed lichenoid drug eruption, a nutritional deficiency, psoriasis, or a burn injury?
Our ARS may not be lecturing. Okay. Oh, yeah. You know what, you can just tell people if they want to, if they, you know what, actually, there's not a great chat option. Just think about it.
Okay, so just think about it. Think about what you would enter into the audience response system were it to exist. And the answer here is C, a nutritional deficiency. I'm glad actually, because now I don't get to know how obvious this was for you. It always makes me feel weird. So this is, these are the cutaneous signs of pellagra. What we see here is a photodistributed rash. And we'll get into what pellagra is. This is niacin deficiency. A photodistributed rash with relatively well-defined plaques. And we describe classically this appearance of peeling pain, not paint, not pain. I don't think that's a Freudian slip, or a shellac-like scale. And so shellac is that ingredient used in manicures, which can just really peel off easily for those of you who've experienced it. And what pellagra is niacin deficiency. So I hope this brings you way back to biochemistry, this pathway by which tryptophan gets converted into niacin, nicotinamide, and ultimately energy, which is used to power all of our cells. When you lack niacin, you have pellagra, you have a distinctive dermatitis that mostly affects sun-exposed areas first. And it's interesting why that is, but basically what happens when they are deprived of energy resources, when you cannot synthesize that NAD plus and ADP, the skin cells are the first to become sensitive to sunlight. The ones that are in sun-exposed areas, they're the first ones to show signs of damage. So the sun is very damaging to our skin, and the areas that are going to see this rash first are the ones that are being directly bombarded by it. Some other examples of how this looks, you can see these well-defined plaques on the foot that are scaly. You can see similar well-defined plaques on the arm here. And another cases of my colleague from Ethiopia showing the same photodistributed, shiny, well-demarcated plaques. And we call this Castillo's necklace. This is just describing the appearance of almost a necklace-like eruption because of how well it is defined around the collarbone, again, depending on the type of shirt that your patient is wearing. And what was interesting about our case was, again, I was telling you that we were starting a dermatology clinic at the Infectious Diseases Institute, all patients there living with HIV. And I was called into a room by a primary care provider to take a look at this rash. And this was kind of a slightly different morphology. You know, these are more discrete plaques that are in some cases coming together to form larger lesions, but same exact sun distribution. And you can see the Castillo's necklace forming around the collar. You see the lesions on the forearm. And I was also really suspicious. And so this made me wonder, was there something going on here that I was missing? And in fact, we saw several cases within a short period of time of pellagra, which is something that I just never really had seen before. And so my question for you is, what were some of the contributing systemic factors behind these eruptions that we were identifying? Was it that prophylactic isoniazid was being used for TB prevention? Was it that most patients here are on a maize-based diet? Was there an introduction of a new soap covered by the formulary in the local healthcare plan? Was it just the first two, or all of the above? So I'll give you a chance to think about that. And in fact, it is actually the first two. So this is one of the key points that I want to get across. So what was happening was that, you know, typically we think about testing for TB. If we identify latent TB, we initiate a prolonged course of isoniazid. Of course, if we identify actual TB, we're on multi-drug therapy. But what was happening in this setting was, because of new Ministry of Health rules, isoniazid was being used in a much more widespread fashion for what was called TB prevention. So people are being on this medicine for about 6-month courses periodically to prevent the development of TB in a really high prevalence area, because the implications of having TB, especially in uncontrolled HIV, were really serious. And so a lot of these patients, as a part of being patients at the Infectious Disease Institute, were being dished out isoniazid to take very frequently. And in fact, what was going on was the full story with our patient is that, 44-year-old had been given a 6-month course of IPT, isoniazid preventative therapy, as well as pyridoxine. As we might recall, isoniazid alone can induce B6 deficiency if you do not replace that vitamin. And this was a part of this nationwide effort that I described. 4 months into her therapy, she got this symmetric, photodistributed, well-defined rash that we described earlier. She had no GI or neurologic symptoms, which would be typical more of B6 deficiency. And what was happening here is that even though you classically think of isoniazid as B6 deficiency, it can also cause vitamin B3 deficiency, especially in susceptible hosts. And the reason that that's happening is that isoniazid acts as a structural analog of niacin in this pathway and can interfere with the conversion of tryptophan into the nicotinamide that your cells need to power themselves. And so what that means is that isoniazid can cause pellagra, even if you give B6, because by a different mechanism, it's causing this other problem. And that was new to me. That is not something I had experienced before or encountered, and I hope educational for you. And so we published these cases in a case report immediately, basically, because there wasn't enough literature available to give guidance. And the guidelines here were that for people practicing in areas among patients where, for example, maize is a staple dietary carbohydrate, which was definitely true in the part of Uganda where we were, you should consider checking some baseline labs before you initiate this. Now, thinking about our setting here, which we'll get into a little bit more, we have a lot of patients who are experiencing food insecurity or don't have a complete diet in terms of their ability to get all of the amino acids that are needed to thrive. And so there might be certain patients who are food insecure, or maybe through taking a food history, you realize are not getting a complete diet, who would also benefit from this testing. And what you can do is initiate a B-complex vitamin or specifically nicotinamide supplementation at the onset of treatment. If you identify this and the patient must continue the preventative therapy, either because they have latent TB, in our case, for example, you can supplement with these vitamins and also do a lot of counseling about niacin-rich food sources, which include liver, chicken breast, marinara sauce, tuna, brown rice, peanuts. And then for people who have really severe symptoms, we withdraw INH and offer alternatives. And what happened in our case was she had already gotten these 4 months of therapy. She didn't actually have a case of TB that we were concerned about. And so we withdrew the medicine. We started her on the B vitamin that was available through the formulary. We gave her some steroids for itch, and at 4-week follow-up, her rash was completely gone, which she was absolutely thrilled about. And it was very gratifying to see how dramatically this improved for her. And she had been really struggling with this. No one had really been able to identify. So there are some really important skin signs of nutritional deficiency to be aware of. Some other patients, populations that are especially vulnerable to this are people who, for whatever reason, have malabsorptive gut disease. Other medications can inhibit this path. There are patients, for example, who have carcinoid syndrome, which steals tryptophan away from the pathway in order to make serotonin. And so you can get niacin deficiency through that route. And then there are genetic disorders where you have impaired tryptophan absorption, like Hartnett disease. And so things to keep in mind, especially for our patients who are struggling with food insecurity or who have other reasons to be deficient. And then what I just wanted to point out is to have an opportunity to show you some of the other skin signs of nutritional deficiency, because again, we have a lot of food insecurity among our patients. So these are skin signs of scurvy that I shamelessly pulled from the internet, and I'll also show you some real photos in a second. What you're seeing here is hair. So when you have scurvy, your blood vessels lack integrity, and the ones in the skin are going to show that by rupturing in a minute way. And one of the areas where they rupture first is around the hair follicle, where there's weaker integrity of the skin. You can get these perifollicular hemorrhages. You can also get diffuse bruising or purpura. And finally, you can see these little corkscrew hairs, which are classic. And this is more common than you would think. In high-income countries like ours, it affects up to 1 in 10 women and up to 14% of men, because even if you think that your patient is well-fed, maybe they're not underweight, they might not be getting the types of food that are going to source vitamin C for them. And so some risk factors for this, I'm mostly a pediatric dermatologist. Besides doing HIV, I think a lot about kids with autism spectrum disorder who are not mindful of what they're eating and might have really specific and picky needs. Folks with eating disorders, those with iron overload syndromes, malabsorption diseases, people experiencing homelessness, or those who have low income, and also pregnancy just because of higher requirements of vitamin C. You might see these in this patient population. And what I wanted to point out and share was that what really inspired me to share these cases with you actually was Herbert recently gave grand rounds at our department and shared this really impressive case that taught me a lot of a patient that he saw here at the General who had scurvy, which cutting to the chase was evidenced by a large intramuscular hematoma. So in addition to all of the signs that we talked about on the skin, you might have orbital or eye issues. You might have large hematomas develop within the musculature, which present with purpura and bruising on the surface. You can have painful bleeding into the joints, really severe debilitating pain in the legs, leading to a reluctance to walk. And ultimately, if untreated, scurvy can, of course, lead to death. And so these are the images from Herbert's case, which I appreciate him giving me permission to share. These are some other faces of modern scurvy that he allowed me to also share with you, just showing the vitamin C was ultimately checked in these patients and that it was low. And one of the factors that really he was able to identify in his case was the fact that this patient had a diet and was eating, but was not getting any of the food sources where you typically associate with vitamin C. So citrus fruits and other fruits that are going to give you that. And so you might think that you've taken a nutritional history, but if you're not really asking, getting into what they're eating, or maybe you lack the cultural familiarity with what the things they're eating are, you might not really realize that they're not eating things that are going to source this. A couple other skin signs that I want to point out are this flaky paint dermatosis that you can get from diffuse protein deficiency, which we do see in some of our patients. This is a skin signs of kwashiorkor. You can also just get this diffuse dyschromia with hypo and hyperpigmentation as a result of decreased protein intake. This is a baby with signs of zinc deficiency. These signs can happen in all patients, but basically these periorificial eroded plaques that are pretty well defined. And then we get so many consults, countless consults for hair loss. There are numerous causes of hair loss, as many of us are familiar, but I do sometimes obtain a nutritional workup in patients who have a sudden onset of diffuse hair shedding with no clear cause, in addition to checking things like their thyroid. I'm wondering about anemia, wondering about vitamin D, wondering about B12, zinc, some of these key ingredients that are the building blocks for new hair, where you just cannot synthesize new hair if you don't have these key ingredients. And so things to think about. We see a lot of folks with angular cheilitis or this inflammation and these superficial plaques around the corners of the mouth. That can be a sign of B vitamin deficiency. And then there are rare skin signs of B12 deficiency. What I was able to find in the literature, but haven't actually seen myself, are these hyperpigmented areas, typically on the feet and on the hands. Excuse me. And so finally, last case, this is actually case 5. Not case 6, is another patient that I saw that really taught me a lot at the Infectious Diseases Institute in Uganda. She was 40 years old, well-controlled HIV, absolutely no history of acne whatsoever, coming in with an abrupt onset of densely clustered acneiform papules and pustules on her central chest. Her face was relatively uninvolved, and she was very disturbed by this. It was stigmatizing to her. It was leaving behind hyperpigmentation. And you can see close up what some of these look like. Although there are multiple stages of healing here, there's a lot that are in the same stage. So relatively uniform from the perspective of acne. And so my question for you is, what's the most likely etiology of this rash? Was this hormonal acne, a medicine reaction? Did she have hot tub folliculitis? Is this staph infection? Or is this a skin sign of scabies? I'll give you a second to think about that. And this is a medication reaction. So on the theme of Herbert's 6 drugs cases, I wanted to share with you a little bit about drug-induced acneiform eruptions. So the classic drug-induced acne patient is going to present with a relatively monomorphous inflammatory eruption, as opposed to the more classic polymorphous lesions that we see in patients with acne. And what was interesting, well, let me get into this and I'll go back to our case. There are a lot of different medicines that cause this. For example, I was recently in my peds derm faculty practice and have a patient with well-controlled bipolar disorder on lithium who came in with really debilitating acne that had developed in the years since becoming stable on that. We, of course, need to continue that treatment. And so we're faced with how we're going to address this drug-induced acne. There are various chemotherapies, vitamins, and other medications that are associated with drug-induced acne. And I want to go over a few examples of that. So this example is near and dear to my heart. This is a patient who has been putting topical steroids on their face. And when you look at this patient, and oftentimes they're not a teenager, that's often one of your clues, but maybe they are. But what you can see here is that they're really uniform. They're very papular, and a lot of them don't come up to form true pustules. And so this monomorphic papule and pustule rash is happening at the site of steroid use, and this is suspicious for steroid-induced acne. And one of the things that I have seen a lot, especially in Kenya and Uganda, is patients putting on medicines to their skin like steroids with the intention of causing skin lightening. We're always counseling on the harmful side effects of topical steroids. If you put them on forever and ever and never take a break, we know that they can thin the skin, lighten the skin, lead to pigment alteration. But in some settings, people are using them for those secondary consequences that can occur. And of course, lots of downstream negative effects of that, one of which is steroid acne. And I've actually seen a lot of corticosteroid-induced acne in patients trying to use steroids to lighten their skin. You can get this when you're taking systemic corticosteroids. So we actually see quite a few e-consults that look like this. Patients come in with these monomorphic inflammatory papular eruptions, often on their chest and back. And this is clearly not classic acne. It's very robust. It's almost always in the same stage. And this is a case that's slightly a different flavor. So we have patients who are on anti-cancer medications and specifically EGFR inhibitors who have this acneiform eruption, but it almost has a little bit of an eczema flavor to it. And when you see that acne plus eczema in your patient, who you of course will know is on these medicines, that is something that we actually address differently with doxycycline and topical steroids to get it to calm down. This is another example of that kind of acne eczema overlap that you can get from these EGFR inhibitors. This is a patient who is HIV and living with HIV, relatively well controlled, who came in with a new rash for the prior month, and he had been taking testosterone for low testosterone. So similar to corticosteroids, some of these androgen hormones can have these same effects. Again, you get these monomorphic papules, often on the shoulders, chest, and back. And you can treat this with topicals. You can also treat this with oral isotretinoin. And I just wanted to bring up the case that we have actually several patients in our HIV derm clinic who are taking testosterone therapy at higher doses for gender identity, treatment, who are, female to male transgender patients. And they are often on high levels of testosterone and the acne that you can get from that is really severe, especially in the first few years. And these are patients who I often will have to initiate oral isotretinoin or Accutane, maybe even a TNF-alpha blockade to get this acne to come under control so that they can still have their goals of care met. And this is something that I see also a lot in my teenage patients. And so something to be aware of, something to know that we can treat, but different from your classic acne and can be really, really wild and difficult to control. And so back to our case, what we identified in this patient was that she had been taking isoniazid, again, for preventative therapy. And so same culprit, different manifestation, isoniazid, just like lithium, testosterone, corticosteroids, EGFR inhibitors can cause an acneiform eruption. We stopped her medicine. We did nothing else, and she was better. And this was her 8 weeks later, really, really satisfied with her response to treatment. And so just to keep in mind, drug-induced acne is managed very differently, typically from classic acne. You might have an older patient with no history of acne as clues, but really doing a thorough drug history in a patient with a new acne rash is important. And if the offending agent cannot be withdrawn, many patients can be treated through their rash. Depending on the culprit, we have different approaches, and we start seeing a lot of these patients in our clinic here at Roy 86. And so take-home points, should I say your take-home points? Okay. So Herbert went over the science of Mpox and the typical progression of lesions from macules to papules to vesicles and pustules. And then this concept of reinfection in patients who have had a prior infection. Vaccination is possible. It's not 100% protective, but is still very helpful. And a lot of that was hot off the press. We know that fixed drug eruptions can create these really mysterious oval, sometimes multifocal eruptions. And when you see eroded plaques on the genital area, especially if they have that oval morphology, think really hard about some of the medication culprits because there are a lot of them. And we know that this can be associated with doxypep, which is more and more prevalent use in our community. There are multiple options for acyclovir-resistant HSV, including intralesional cidofovir injections, topical imiquimod, and trifluridine, and there are emerging treatments that we reviewed, such as oral pratelivir. There are many skin signs of nutritional deficiency. I think it's one of the things that we underappreciate. And I also want you to keep in mind that when you're thinking about your patient, the patient in front of you, they might not be the typical thing that you think of for nutritional deficiency. Maybe it seems like they have a full diet. Maybe they say they're eating 3 meals a day, but you really need to think about what the contents of those meals are and how they could be contributing to not just their skin signs, but overall health. And then finally, drug-induced acne from isoniazid, as I showed you, but also testosterone therapy, steroid use on the skin or otherwise has a distinct appearance and a management approach. And we are more than happy to help with all of these things. And I just want to say really privileged to be able to be here with you today, working on this Ward 86 is like the highlight of my life and my total dream. And so I really appreciate all of you being here.
Thank you so much. Thank you.